Hello, and thank you for joining us today. My name is Joanne Ferrara, and I'm the Marketing Director at Dymedso, and I'll be your host for today's webinar for part one of a two-part series on the impact of sound on airway clearance. Today's presentation will be given by Don Sizemore, President of D&D Medical and a Dymedso business partner. At the end of today's presentation, we will have a brief Q&A. Please type your questions in the Q&A panel, and we'll address them at the Q&A session. We are also recording today's session and will make it available to you later on today. And now I'll turn it over to Don.
Thank you very much, Joanne. My name is Don Sizemore, and as Joanne mentioned, I'm a Dymedso partner, have been for about 7 years. And while I am clinical as well as technical, I did want to make sure and let you know that this is not to be considered a clinical training. So it's more of an education on technology and how the device works with the human physiology. So we'll jump into it. And you'll notice the screen says pulmonary hygiene, mucus motivation, and there's probably 4 or 5 other terms that you've had or used in the past that have to deal with airway clearance. So you may hear a couple slips up where I use different terminologies there. I'm going to try to stick with airway clearance for everything during this, but that's mainly what we're speaking of here. So to consider any technology for airway clearance, it's important for us to always go back and review what's going on under natural, normal conditions, what happens in the healthy population, because in the patients that we're treating that are ill and need assistance with airway clearance, we need to find out what's different and figure out which technology will intervene and help us achieve that normal goal. In normal mucus clearance, it's a process that is kind of built into our bodies. The process is not complex. It is simply cilia that are beating to their own frequency, and they are beating in such a manner in a directional motion that anything on top of it should move. And what's on top of it would be excess mucus in a sick patient. So normally when there's excess mucus, the cilia, they beat and move it. So a couple things to note on that is that mucus in those patients is often thicker in viscosity than it should be. Their bodies are not keeping the viscosity of that mucus at a level that allow the cilia to move it. A great example of how this process works in the normal body can be understood by looking at a stadium. If you go to the football stadium and you watch, the fans are excited, someone throws a big beach ball up in the air. If the people were like the cilia and everybody jumped up and pushed the ball or hit the ball to the left, it would make its way and move around the stadium. And this is much like the cilia are in the airway system. So they're beating like the people jumping up and hitting the beach ball to the left, and the beach ball moves around the stadium. In the human anatomy, the beating is to move the mucus towards the larger airways where we can cough it up or swallow it to expel it out of the airway itself. So it's really not too complicated of a process. But to learn more about the physiology piece of it, we go to this image, which is directly out of one of the textbooks that they use to teach respiratory therapy in the United States. The thing that is added is the motion in the cilia in this picture. But basically, it explains the process that we just talked about. The natural rhythmic beating of the cilia cells moves the mucus on top of it, and that mucus moves into those larger airways where it can be coughed or swallowed, expelled out of the airway itself, or taken out. So basically, this is a good drawing, and it's a good time to stop and think about if the mucus were too thick or too heavy. And going back to our stadium picture, imagine if you were at that stadium at that football game and someone threw a beach ball up, but the beach ball was filled with water. It was too heavy now. Then the people, just like the cilia, would not be able to jump up and push that ball to the left near as easily if it were just an air-filled beach ball. So it's a great example and helps us understand how that natural process works within the normal healthy physiology. So when we look at the physiology from the nose all the way back to the terminal bronchiole in the airway system, all of the tissues are covered with cilia cells. Some textbooks will say it's ciliated, and that's a little less descriptive, but the cilia are the little hair-like structures that beat to move that mucus around. In addition to that, all of the surfaces are normally covered with a thin layer of liquid. That liquid goes by several different names. Solute is one that's in the textbooks. I've heard airway surface liquid. I've heard mucoid coating, but that liquid has its viscosity controlled by the body, and it keeps a pretty tight rein on what the viscosity is, because if it gets too thick, then it will mute the motion of the cilia and the beating. If it gets too thin, then it won't support anything. But one of the jobs of that coating or that layer of liquid is to also reduce friction of moving the mucus itself off of its current position and in a direction toward the larger airways. So once we get to those larger airways, then it can be expelled. The physiology of an airway, again, pictures right out of the textbook called Mosby's that they used to teach in the United States for respiratory therapy, states the physiology of an airway. And you can see on the left, they have that divided as two different sections. And it's important to note the functions of these two sections of the airway system. The top portion of it is what they term the conduction zone. It's where large amounts of air move in and out with our breathing. And then it goes and it divides and splits up into very small lower airways, where actually most of the work of respiration takes place. In the work of respiration, of course, is the gas exchange through the alveoli beds that takes the oxygen and puts it in the blood and the CO2 and all out of the blood, the toxins and everything. So just looking at the picture there, one of the things to note that I've seen and read, that if we could lay all this out flat, and the surface area within it would cover a tennis court. And that's a lot of surface area, but it's important to notice that most of that surface area is going to be in the lower airways, down in the smaller channels. So that's going to be important, because if the work's getting done there, we need to make sure that any airway clearance methods we're using are getting down to those smaller airways and not just clearing the larger airways. There are many, many reasons and illnesses and diseases that cause patients to need airway clearance. There's a few of them on the screen. There's many, many more of these. Some of these diseases are congenital in nature, patients born with it. Some of them have it their entire life. Some of them are acquired diseases, even environmental diseases. Some of them are behavioral and some of them are even medical. So there's a lot of reasons that a patient's body may need help keeping the mucus out of their airway system to allow the entire pulmonary system to do what it's supposed to do. And we don't always control why we're having to do airway clearance, and also just knowing that all of it's not the same. It all ends up with mucus that is blocking the way of what we normally would consider as good airflow or volume flow or functional resistance. There's a lot of things that we can put into that category. So it's important to clear those patients' airways. We have to ask ourselves why we're really clearing the airways. And I think the number one most important reason is so our patient can feel better and can breathe better. That's probably one of the most difficult things, is to have difficulty breathing. It's tasking on the body. It basically tires you out and wears down to where there's just no way you can feel good. And that should be our number one reason to clear the airway, but there are other reasons. We mentioned that the alveoli beds and all are in the smaller airways more than those larger airways. And they can't be very efficient if the good oxygen-rich air can't get to them, and if the toxins and CO2 and so forth cannot be transported out of the body. So that's your primary reasons. This, of course, allows their percentage of oxygen to rise, and it starts a chain reaction of processes that ends up with them feeling and breathing better. So airway clearance can play a major role in a person's overall health. There are some other reasons. We may need to get a good untainted sample of mucus that we can send to the lab for testing. Oftentimes, if there's areas where the mucus is plugging or blocking, then if we get a sample from that area, it may contain medications, it may contain other environmental toxins and so forth that we would rather not have the lab have to deal with. But we've all probably been experienced it, where you've worked really hard to get a sample and send it to the lab and it comes back as a tainted sample and you have to repeat the process. It's extra work for the clinician and it's extra discomfort for the patient most of the time. So those are the primary reasons that we are clearing it. That's the why of clearing the airways. If we go back to history and look at airway clearance over the years, there's a lot of different names. Just like I mentioned on the initial slide, there's a lot of them you've probably heard that I haven't, but CPT, clapping, cupping, beating, all kinds of terminologies come out there. But basically, I couldn't find a date of origin. Where did all of this start? But it goes back pretty far into today's, when medicine wasn't so technical. We did find references to the early 50s and possibly the late 1940s that talked about putting a patient on a table with the head in the lowered position so that gravity could assist, and beating on the patient's back to get the mucus to shake off of the walls, off of the cilia into the flow, where it could be transported into the larger airways and again be coughed or expelled out of the airways, or perhaps out of the airways and swallowed, whatever it is, to get it out of the airways so the airways can do what they do. The interesting thing with it is it became a true therapy. It got a couple extra names and it got a little more science behind it. The cupping using cupped hands and even cupped devices versus flat hands and all. Stayed around for many, many years, and there's still a lot of good that is done with cupping and clapping on a patient. There are other pressure therapies that were designed to basically chop the patient's airway. When we exhale, there's pressure going out, and when we inhale, there's pressure sucking in. So if we chop that pressure, the on-off cycles should make the lungs shake, and the airway system that's attached to it shake as well. And by shaking, perhaps it would release the excess mucus from the cilia and from the walls of the airway system to where, once again, it can be moved into the larger airways and expelled or swallowed. So for years, that was all we had. And for now, there's a lot of drug companies. I don't know if it's international or not, but a lot of drugs out there show some real promise. Most of the solute in the mucus has its viscosity controlled with fluids, and the way the body handles the fluids can alter that viscosity of mucus and viscosity of fluids quite a lot. So there's a lot of drugs in research, and there's a lot of drugs out today that can help a patient's body keep those viscosities at the right levels so that mucus can be moved through the system and expelled properly. Again, I don't know if that's everywhere or if that's just where I'm exposed to in the United States, but it shows some real promise, and we hope that that continues as well. All of the other therapies that you see on the screen, other than drugs, are mechanical in nature. And we want to remember that for later on when we start looking at sound in the physiology, because they're two completely different types of energy. And just keep that in mind. We'll revisit that, and you'll hear it over and over again. So that's where the history of airway clearance is. And we have to ask ourselves, so this mucus that we're getting out, what is it? Why? How is it made? What affects it? And you'll see on the pictures on the screen that there's a few big words there that don't really, they're engineering terms that we use in engineering, but mucus is a viscoelastic gel or a non-Newtonian material. Again, those are engineering terms that mean its strain curve or its drying or solidification curve is not linear. And all that means to us is that in a still, motionless state, they get thicker. And recently, a good example of this is all of the new gel paints that have been developed. In the old days, if you put too much paint when you're painting a wall, you end up with drips or runs that don't necessarily look good. So the paint manufacturers decided to change the way they make their paint and offer a product that is a non-Newtonian material, and it's gel paint. If you were to go to your local hardware store and very gently pry the top off a small can of gel paint, you can usually flip that can upside down and then flip it right side up, and nothing happens. The gelled paint is solidified to the point to where it does not run out of the can. However, one of the properties of this type of material is that if we change its physical shape or size by altering it, stirring it, shaking it, it reduces its viscosity naturally. So if you took that same can of paint and you shook it up before you took the top off and you flipped it upside down, it would be all over the counter. So it would alter its viscosity based on you altering its physical shape by shaking the can or stirring the paint before you turned it upside down. And that's a pretty good example of the way mucus is. Some texts and some pulmonologists believe that the beating of the cilia is similar to stirring the gel paint. It's stirring the mucus, which would alter its physical state, which would cause it to reduce its viscosity, making it easier to move, making it thinner, basically. So I hope that example gives you a little bit of a history on the type of material that we're dealing with and some other uses of those properties. And again, stirring or altering its physical shape causes it to run or reduce its viscosity. By the way, on paint, it works really well because the drying curve, as we thin it, lets it dry and you don't get runs in that type of paint. Okay, so currently we have 4 tools that we can use for airway clearance. And when I say tools, I'm not talking about individual devices. I'm talking of technologies or ways to do airway clearance. There's 4 main types, and we'll talk about these individually because recently we have added sound. And sound is a new technology that is very unique in its properties and how it works with the physiology to help it with normal airway clearance. And we'll discover that, and we'll dive into it fairly deep in the next section and at the end of this section. But I want to go through each of these to explain what we mean by them. Direct is a technology where we directly remove mucus. And it's obvious that this must be done through a device, whether that's a standard suction catheter or through it's a suction port on a scope or any other method of physically removing that mucus through a device. There's a few challenges with this. It works great when we're doing a medical procedure, or it works great on a patient in the ICU that their normal body processes are just muted. We can suction those patients and get a lot of the mucus out. However, we can only get out as far as the device will reach, and the airway system can only go so far with these types of devices. You can't get them into the smaller, tinier airways, obviously. And again, going back to our slide from the textbook, this is where most of the work is being done. So while it's a great tool to have in our toolbox, we also need to clear those smaller, tinier airways. Sometimes this procedure needs a medical facility or specialized equipment. Sometimes it needs a clinician or perhaps a caregiver, if it's outside of the acute care structure, to do this. I don't think I've ever seen a patient that suctioned themselves. I'm sure there's one out there somewhere, but it would certainly be a challenge. So this is the direct method of removing mucus out of the airway system. The next category is going to cover quite a few products, one of which is on the screen and you're fairly familiar with it, but it's mechanical methods or mechanical technologies that are supposed to help us get mucus out of the airways. They work fairly well. They have some different reasons that there's challenges and so forth. CPT is one of the earliest forms of a mechanical airway removal process there, where we use our hands to try and create a mechanical wave of energy that is designed to shake the airway system or shake the lungs to get the mucus to dislodge from the cilia and the airway walls so it can move easier in patients that don't have the right viscosity in their mucus, or perhaps the solute is too thin and doesn't help reduce the friction enough. If we did it manually, then it only follows reasoning that someone was going to invent a mechanical device that used electricity. As we progressed, we went to the percussors. I don't know that percussors were available all over the world, but the percussor was simply a device that had a pad on it that had an off-centered weighted shaft in it. And as that shaft spun, it caused that pad to shake, and that shaking would be applied to the patient's airway by putting the pad up and down the patient's abdomen and chest to hopefully shake those airways. Again, that's a mechanical intervention that we had. And then we moved on to, if that works, perhaps a high frequency chest oscillation device or a vest would work. I know vest is a patented term, and there's many other devices that are similar in nature, but the way they worked was simple. You wore a garment or some type of a cavity that would inflate and deflate very rapidly through a pump or hydraulic type device that would shake the patient all the way around. A percussor would apply its energy from one side from the pad. The percussive device would apply that mechanical pressure from all the way around the patient by inflating and deflating the garment that it's attached to. And it's important to note that all of these devices use mechanical energy. Again, we'll keep referring to that because the new technology in sound is very different. So these devices are available. Typically, they'll have some adjustments on them as to how hard they shake. They'll have some adjustments on them as to how fast they shake or inflate and deflate. But basically, it's the same concept of rapidly shaking or vibrating a patient in order to cause mucus to dislodge from its current location, where it can be moved into those larger central airways and then again be coughed out or expelled out of the airways. So once that mucus moves, then the cilia are free to beat and move under their normal process. The vibrations can alter the shape of the mucus, and when they do that, the mucus would thin. However, our bodies are designed in such that we absorb most mechanical energy, closer to the surface of the skin. And it's important to think about that because anything we do like this is going to work better on the larger airways and all. And you'll see in the drawing on the screen that a surface wave of energy doesn't penetrate deep enough to get to those smaller, tinier airways, or if it does, the patient won't be able to tolerate it. And our bodies are designed this way. It's why we can get into a car wreck and not die from the injuries of a fast stop or hitting the steering wheel, things like that, because the body, again, absorbs those energy waves, the mechanical ones, and it actually shelters those smaller, tinier airways from that energy. And it prevents them from getting all of that motion, which prevents the effectiveness that we do see in the larger airways. So that's the mechanical category. The other category that we talk about is vibratory. I've heard it called vibratory positive pressure airway therapy. I've heard it called airway oscillation devices. And you're probably familiar with some of them. There are many of these devices that have been developed over the year. They're fairly simple in nature. Since we do create pressure when we exhale or inhale, we could have our patient blow on a device and force that pressure through a device that would have a mechanism that would shake or release and then close. There's all types of methods, but it basically chops the airway. And you can imagine if you had a balloon that the air was trying to get out of it and you were able to chop the air as it exited, the balloon would shake, it would vibrate. It's much like the lungs when we blow on one of these devices. And the goal of it is to shake or vibrate the airways to where the mucus is dislodged. As I mentioned, there are many of these devices in the market, and even some of them are designed to work on the inhalation versus the exhalation. The reason they're designed that way is because these devices require the patient to be coherent. It's a patient therapy, patient-driven therapy, not a clinician-driven therapy. So we educate the patient and then they do it on their own. That's a good thing because they can continue their own therapy once they leave the hospital or the clinic and use this at home. It's better than not doing anything at all, because not doing anything at all just simply allows the mucus to continue to build, making it even more difficult to get out of the airways. So realizing that some of these patients don't have enough health, they don't have the stamina to blow one of these devices to make its mechanism activate and start chopping. There was a need for something else. And again, they've tried the inhalation cycle, thinking maybe there's patients that they're too sick to generate enough pressure on the exhalation portion, but they're well enough to create enough suction pressure on the inhalation cycle. I've seen 2 or 3 of these devices that have been created in the last couple of years. They're all designed with some type of pressure required to make them start working. Probably in the early days, some of the worst devices would require upwards of 15 or 20 centimeters of pressure to make them work. And of course, you've probably all seen more than I have patients that didn't have but 2 to 5 centimeters of pressure when they exhale their hardest. So it's easy to see how they can have some patients that wouldn't be compliant with this therapy over long periods of time. That's one of the challenges with a lot of the mechanical devices is when we're early on, it doesn't seem to be such of a challenge to use it. As a matter of fact, I've put a vest on patients and they say, oh, this feels good, I like this. And they come back for treatment later and you find out that they haven't been compliant with their therapy. And when you ask them why and dig into it, it's because I didn't feel good. I felt sore that day and didn't want to wear it. Same thing with these devices. You ask a patient if they've been using it and they'll say, well, somewhat. I've missed a few sessions. And when you ask why, it's typically because they didn't feel like it. And really, I think it comes down to a balance in their mind of, does the pain of using it offset the pain of not using it? So again, these devices are better than nothing. They work to some extent. Even, the beauty of it is they can continue it when a clinician is not present. Some of those contraindications, though, and before we leave this, they do work better on larger than smaller airways. And with the other products, this is a mechanical energy as well. So it has the same outcome. It works better on larger airways than it does the smaller, tinier airway, just due to physics. One of the challenges is it only works with the patients that have the physical ability. And then again, there's patients that need the mental aspects. We couldn't take one of these devices and give it to a 1-year-old and expect them to use it and use it properly, even with parental guidance. So there is an age window. Some senior devices may not have the comprehension to use the device as well either. So the device is great. It works. It's better than nothing, but it could be better. So we'll move on and look at the contraindication for some of these mechanical devices that we've talked about. The first one is, of course, patient toleration. And everybody's had a patient that, well, I shouldn't say everybody. Some of you have probably seen a patient that was supposed to have CPT or cupping, and they just didn't feel like it. They didn't show up for their appointment. They stopped halfway through their treatment because they just couldn't tolerate it. You've seen a patient that had a vest at home and they said it hurt, so I only used it for 5 minutes. I couldn't use it for the full 20 minutes that you prescribed for me. Things like that they all boil down to patient toleration. And I think that's the main reason some of these mechanical devices aren't as effective as they could be. Wound locations is another reason some of these devices can't work or are contraindicated. A lot of times you'll have a patient that goes in for surgery and maybe has a open chest. You know, they have heart surgery or something. If they needed airway clearance before they came in for that surgery, they're still going to need airway clearance. And I think in the United States, we often lean more towards changing to drug therapy and other methods of airway clearance, because the mechanical methods that they may have used before are now contraindicated. That's just some of the things, or perhaps the patient just hurt themselves and the therapy they've been using no longer works for them. There's other clinical conditions that we need to consider. Some of those here in the United States, we have several areas that black lung is a prevalent disease in the airway system in the lungs. And there's other terms for it, but a mass of solid tissue is in the walls of the airway system. If you use mechanical energy and you're vibrating that hard mass or moving that hard mass rapidly, it tends to injure the cells around it. And when it does, we have to weigh the benefits of airway clearance versus the possibility of creating a larger mass of damaged tissue in the airway walls. Pregnancy is a great example. I've seen patients where they've used a mechanical device, whether it's a vest or a percussor, and they become pregnant. And then their device is no longer indicated for use for perhaps causing injury to a fetus. So that's another example. We have some cancer institutions that use these types of devices, and they say, you know, we can't use these once a patient's red blood cell count gets down to a certain level. So there's all types of other considerations that can make the mechanical interventions no longer valid on a particular patient. Another example of that is a patient that's in a car wreck and now we need a chest tube in the ER. If that patient used one of the devices like a vest for airway clearance as a standard therapy daily, and now they have a chest tube and they're going to be in the facility for a few days, that is now contraindicated, and we need to look to other methods to assist with airway clearance. So it's just a few of the different ways that we need to consider. So we've talked about the three methods, and now we have a fourth method that we're pretty excited about, using sound to help us or help the patient with airway clearance. We're going to get a little deeper into this in our next session, but during this section, we need to explain what sound is. Sound is an electromagnetic energy that creates a pressure wave in the environment that it exists in. So that's a pretty simple definition, but sound is an electromagnetic energy that creates a pressure wave. And we're going to use that to help people clear their airways. We will be learning about several characteristics of sound in the sound energy in the energy waves that are created. But there's two of these that really stand out when we talk about assisting with airway clearance. So the two methods are listed on this screen. We're going to use one of the properties of sound to allow us to transfer energy to the cilia, and that should allow them to function with what they do better under situations where they're not at their peak efficiency. So they have excess mucus or thick mucus on them. If we could give them just a little more energy and help them move and beat like they normally do, then they would be more efficient, and it would start that chain reaction that makes the patient better. So that's method number one that we're going to use. Method number two is also important because sound does something that mechanical energy is not as good at. Sound causes a reaction to the mucus itself. Earlier, we talked about the mucus material, and we said that if we alter the mucus, the physical shape and size of the mucus, or we stir it, anything like that, then it will automatically thin its viscosity, and that will assist the body with normal processes. Sound can get to the mucus where our mechanical energy waves may not be able to get to that smaller, tinier airwave and cause a reaction in the mucus that's contained within it. Before we end this session and move on to question and answer, I want to show you a video. This video lasts about a minute, and it's going to show us how sound is going to cause a reaction in the mucus. So we'll take about 60 seconds here. Okay, so I'll take just a moment to explain what you saw, and then the next session will pick up on why it happened and what caused it to happen. So what you saw there was a material that was designed to be as close to mucus as possible. In medical research, there's often substitutes, so you couldn't obviously use real mucus for this demonstration or test. The material is a non-Newtonian material that is very close to mucus. And when sound was applied to it, you notice that it, before the sound was applied, it was in a still quiescent state where it was a gel, more of a solid film covering it. Once the sound waves got to the material, it started moving it, which its viscosity reduced enough that it started dripping off of the side of it. So imagine if we could create that reaction in the mucus in those smaller, tinier airways using sound waves, how it could possibly help the patient move all that mucus out into the larger airways. So that's the end of the material for today, and we'll entertain questions and answers.
Oh, great, Don. Thank you so much. You did an excellent job, and I found the content really, really interesting. So I am looking forward to part 2 next week. So you just really quick, Don, you did show earlier the small handheld devices that are used in the mouth, and then you showed the vest. If they both work on clearing the larger airways, is there one that's better, and can you tell us why?
Most certainly, and oftentimes that question is out there. Why not just use a smaller handheld device? Obviously, a smaller handheld device like that costs less, is easier for some patients to obtain, and there's some patients that's all they can do. But the comparison between the two devices you're using the patient's energy or the patient's muscles to generate pressure to activate the smaller devices. And as we mentioned when we looked at them, the patient may not have the strength. They may just be too tired. The vest device runs off electricity. And if you have electricity, it doesn't get tired. It has stamina until it gets unplugged. So there's the length of time, the stamina with the patient, as well as the adjustable nature of it. The vest can be adjusted. It can be stronger, weaker based on patient toleration. It can be adjusted with the frequency that it inflates and deflates. And the smaller handheld devices don't have any of those capabilities. So while it's good for a patient to use at home, some patients have a vest at home, and that's good if it works for them. But if not, then anything is better than nothing in that scenario. Does that help explain the differences for you?
I think so. And just actually to elaborate on that quickly, you mentioned that there are contraindications with those other devices, and some of them are just as simple as pain or discomfort. What about sound? Does sound have any sort of contraindication?
The short answer on that is no. And that's one of the most exciting things, is that when the other devices that we have in our toolbox don't work because of a contraindication, sound is a new tool that we can use. Hopefully we'll get to where we'll figure out that sound should be the starting method, but at a minimum, it should be a method as an alternative to when there are contraindications to what the patient's currently doing. Sound travels through the body differently. We'll learn about that in our next session, and it travels through the body without all of the negative characteristics that a mechanical waveform or mechanical energy does as it moves through the body's tissues. And we'll see that in the next session, and you'll understand why there are no contraindications. Believe it or not, there are not even contraindications for a pregnant female. So for no damage to the fetuses that have ever been reported or anything like that.
Okay. So Kathleen, I may unmute you just to make clarification. You're asking for a patient with very thick secretions, what is the expected outcome with one treatment? I'm assuming you're asking for the outcome with sound. And so I will unmute you to allow you to talk, and you can tell me if that is what you meant. Actually, you responded yes, thank you.
Okay. Good. Well, thank you for that question. It's a great question. There's a couple of things, and first, a point of I guess, disclaimer or clarification. You've heard me mention tools and toolboxes, and all. I'm a carpenter as a hobby, and there's a lot of different ways to do different things. Nothing is 100% on anybody, and it expands into the medicine career as well. What may work one time for a patient and be great may not work one time, may not do anything for a patient. However, what we typically see on patients is with this treatment, and if you think about the concept, we're going to do the things that help the body work normally. They don't happen immediate. Normally, when we use the device, we start seeing the major results in sound waves about 15 to 20 minutes afterwards. So that's where the benefits peak. The patient starts coughing excess mucus out and so forth, and then it tapers off. Depending on the patient's body and how much they're producing versus how much we're clearing, it may be that 6 hours later, they're ready for another treatment. But obviously, the goal is to alter the way the body functions in controlling the mucus. Some patients, the cystic fibrosis patients, their body's not going to use the fluids properly. It's not going to keep the mucus thinned as well as a normal healthy patient, no matter what we do. But the therapy combined with medications, sometimes they will do one treatment as kind of a kickstart, and then the medications take over. But if there's a reason the medications have an issue or something, they may need to go back to another therapy and jumpstart that. We see all different ranges of patients that see immediate results and use the device for a week. We see patients that use it one time and see results. And then we see patients that use it consistently for forever. So I hate to, and it's not a dodge on the question, it's just there's not a true answer to it. I hope that kind of explains it. And in the next session, you'll probably learn more than you ever wanted to about sound, number one, but you'll probably understand why and how that logic occurs with the different patients, because they all have different reasons they have excess mucus. They all also have a different viscosity with the mucus they do generate, and so forth. It's interesting. I've seen patients that get really clogged up. If they're healthy enough to walk, then that's enough to do it for them. The mucus comes out, they're healthy for a while, and then something happens and they get sick and can't do their normal exercise, and then we're back to square one. We need to get it jump started again. So thank you for that question.
Okay, and then Duke asked about IPV, and I think it's just more pointing out that you really didn't discuss it on the webinar. Do you want to touch on IPV at all for the audience?
I think that the benefits of IPV are significant, and it's a completely different therapy. It uses a combination of flows and motion, sort of like the vibration and air devices do. And I don't think we could do it justice in this format. There are a lot of information webinars and all that are put on by the companies that make IPV, and I'd be happy to share that information with anybody. And I would encourage everyone to learn about that, because the technology truly is, in a population of patients, it's doing wonders. So it's again, it's another tool in the toolbox, finding the right patient for it, and they're set. So.
All right, great. Well, we are getting close to the end of the hour. So I think at this point, if there are no more questions, we will end the webinar for this.